I'd like to thank TB Das very much for inviting me to take part in this very interesting symposium. And I'm pleased to be going last because it allows me to make some kind of broader comment. I first of all want to say that India is a country of enormous energy and innovation and creativity, as we've been hearing. When we're thinking about audacious and very novel innovations in eye care, in order to take them to scale and to reach the population who actually need them, as I alluded to earlier, we have to think about the context in which these are going to be delivered and the health system and how they might respond. This is particularly the case if there is a completely new treatment that comes on board. How is the health system going to absorb that? If there is a new technology, which means that a completely different cadre of person can examine the eye, such as with a drone slit lamp, how is that going to work? Where is its place going to be in the health system? And these are some of the research questions which I'm going to address. So I was asked to talk about operational research, and I found this definition here, which is all about examining processes and structures for improvement amongst interventions that are already being delivered. And I'm challenging you to think a little bit beyond that. We have all these blinding eye diseases which affect the community, but for many of them there are already treatments which have shown in clinical trials to be efficacious. For diabetes, for ROP, top left, for cataract, not for childhood glaucoma, it wouldn't be ethical to do trials on that, but certainly for glaucoma we have a whole load of clinical trials showing efficaciousness of different treatments, but still they are not reaching populations and bringing about effectiveness at that level. So why do people who have glaucoma not accept surgical treatment when this is the treatment of choice? There are lots and lots of reasons for that, which require an understanding of the patient's perspectives as well as the provider's challenges. And we know there's been lots of research that's been done on barriers to accepting services, but there is very, very little work that's been done on interventions which specifically address those barriers in relation to glaucoma and many other conditions which still cause blindness. And I'm going to just illustrate two research projects that I've been involved with in relation to glaucoma and childhood eye disease, just to show you what some of the research questions involve and how to tackle these. So first of all, to draw a distinction between efficacy and effectiveness. Efficacy is the result of controlled studies done in a very controlled manner. And we find out whether a drug works or it doesn't work in a very well-controlled, well-defined situation. However, effectiveness is how well that intervention works in the real world, and the two are not necessarily the same. Moving from efficacy to effectiveness, we have to think, is the drug or the new treatment, whatever it is it available? Are the services there able to deliver it? Are the staff trained to deliver it? On the user side, are patients accessing the service and using the service that is available? And is the intervention, the drug, the treatment being delivered to high quality? If the answer to each of these steps is no, then even though you've got a very efficacious treatment, you may not actually bring about effectiveness in terms of controlling disease in the population of people who need it most. And this is what the research that I'm increasingly becoming interested and involved in seeks to address. So if we take in a scenario here, we have a drug which is shown to be 70% efficacy, let's say controlling intraocular pressure, but only 50% of services actually provide that drug. Your effectiveness is immediately gone down to 35%. If people with glaucoma don't use that service, the efficacy goes down, effectiveness goes down again, and if it's not prescribed properly or used properly, only 25% of people actually use the glaucoma medication properly, your effectiveness at a population level is only 60%. And so one can think of all sorts of different kind of combinations and scenarios, but it's just to make the point that the real world can have a major impact on translating trial findings into reality. So how can we study effectiveness? We need to be cognizant of availability, use and quality, and we have to think often of a package of interventions. Just putting the drug in the hands of the clinicians may not be enough. We have to think more broadly about the context. Does this need to be supported by guidelines and protocols? If this medication is expensive, do we need to think about health financing mechanisms to make it affordable? If it's a new diagnostic test, can this be done by other people? So freeing up highly skilled manpower, for example. This is called task shifting. What impact will a new diagnostic test have? This may completely flood the service with newly diagnosed people who want to be treated, and we need to think about monitoring systems. So if we're thinking about an innovation and to assess how it's going to be effective, we have to think broadly, and the design of the studies may have to be complex, and we have to think about other external things which may also impact on what we're trying to do. An example from glaucoma in Nigeria, I have a PhD student who's doing a trial to see what can be done to improve acceptance of treatment of people who walk through the door, many of them already blind in one eye. He did some qualitative research to try and find out why people weren't accepting treatment when they were told that without treatment they risked blindness, and they came up with a whole host of different reasons, as one might expect. So he is doing a clinical trial of a form of interviewing called motivational interviewing. It's not counselling, because what you do is you try and find out where the person is psychologically, mentally and emotionally towards making the right decision. And if they are putting up reasons or excuses why they're not accepting the treatment, then the interviewer explores those with them and suggests solutions. So it's not the normal health education or counselling as we know it, and it's been highly successful in drug addiction and in many other areas of health. But this is the first time it's going to be used for eye care and in Africa. So basically it's to try and see if people are sitting on the fence, how to get them off the fence and accept the treatment. It's a complex intervention because the interview will vary from patient to patient. You'll have more than one interviewer delivering the intervention, and how the patient engages and responds will also vary. It's not like a drug where you give a dose. And this is Fatima interviewing a patient with glaucoma. He's doing a randomized trial. People with a disease where the treatment of choice is surgery or laser are being randomized to usual explanation or usual explanation with a motivational interview, and the primary outcome is acceptance of treatment and people actually undergoing laser or surgery. The pilot study showed a 35% increase in acceptance of treatment, which I think is pretty impressive. So should this intervention prove to be successful, it has the potential to be used for glaucoma in other settings or in other chronic diseases such as diabetic retinopathy, where we know that the involvement and engagement and decision-making of patients is also very important. So when we're thinking about evaluation of complex interventions, ideally you need to have a phased approach to this. Too many times people have focused just on training staff to do a new skill or to deliver a new service, and it fails because the broader context has not been thought about. So there are these various different phases to go through, and I will describe these in the context of a study that we're doing in Tanzania. And the general principles are that the design, implementation, interpretation has to be participatory, and you have to engage with the people who are going to be implementing the intervention or taking it to scale right from the very beginning, so that there is ownership. This may include the Ministry of Health, for example, as in Tanzania. So if we're thinking about eye care in Africa, it's a big problem. We know children present late, they get ophthalmia neonatorum, retinoblastoma often presents with widely disseminated disease, and the use of harmful traditional eye remedies is common. So a potential solution to this is to integrate eye care for children into the primary level of service delivery. And certainly in Africa, there is an opportunity offered by the Integrated Management of Childhood Illness, which is most ministries of health base their primary health care for children on these WHO guidelines. But at the moment, eye care is not included. So a very small pilot study was done by one of our master's students who took the 10 key activities for healthy eyes in children, which were recommended over 10 years ago but have not been acted upon. And she did a small study in Dar es Salaam, just in 15 clinics with 6 weeks and 1 year follow-up. And this is the poster that she used with messages in Swahili, which the mothers actually loved. They could understand the images or ask questions, and the staff found it very useful for health education, which they were not doing before. Results of the pilot were very promising. The nurses' knowledge improved and their practices changed, and we assessed that by exit interviews as well as by direct interview and looking at medical records. So to think more broadly now about evaluating a complex intervention, there is a development phase where you identify the health problem and identify efficacious interventions. So you're taking things we already know from clinical trials work. And then you think of a theory whereby you intervening, say that the health belief model says that if people's knowledge is improved, this changes their attitude, which changes their practices. That's a theoretical model, so one applies that. And you also have to do a lot of background information about the health system and current service. Then from that you can apply a theory of change, which sounds horrifying and it looks horrid, but the goal is the thing that you delineate first, and then you identify the different causal pathways that need to be in place to achieve that goal. So in Tanzania, there's a pathway of service delivery by staff and changed behaviours by mothers, which could lead to less corneal ulceration and scarring. And on this side, less blindness from treatable diseases. This is the pathway of detection, identification, and referral for services. Once you have delineated these causal pathways, you can then work out what needs to be in place to be able to achieve that. And this is where you actually decide the scope and range of the intervention that you're going to deliver. So here there is training staff, ensuring supplies are in place, training the supervisors, and making sure that record keeping and referral mechanisms are in place. Then you can use that theory of change to go to the real world to find out what is actually happening, to test assumptions and to test potential barriers. And you may want to do then a pilot study, and then the last phase is actually the evaluation. And this often forms is the design of a cluster randomized trial is often used at this stage to measure effectiveness. So if I haven't lost you already, the last step is scaling up. So you've found that your complex intervention has the desired goal, and then you think, well, how is this then going to be extended across the health system? So to come back to Tanzania, after the pilot study, we met with the World Health Organization.
1 minute, Claire.
Thank you. We met with the person in WHO responsible for blindness and explained that this was what we wanted to do. We also formed a steering committee in Tanzania consisting of all the people who would subsequently take to scale any positive findings. We undertook formative research using the theory of change, and this includes all these different methods: policy review, a survey, focus group discussions, and finding out what staff already knew and did about eye conditions. We found from the formative research that eye conditions were common and that vitamin A supplementation coverage was very low. Less than 5% of children had their full range of doses. This means those children are at increased risk of mortality as well as visual loss. Health education rarely included eyes, supervision didn't include any training, etc. So there was a lot that needed to be done. And this needs a package of interventions. We can't just train staff. That will not be enough. This will not bring about effectiveness because there are all these other gaps in the health system that need to be addressed. So we are now we're working with the Ministry of Health to develop the training module, and we're planning a randomized trial to integrate all these different elements into some clinics and not in others, and then to compare vitamin A supplementation coverage as our primary outcome. Our goal is that the Ministry of Health will include eye care for children across the country so that all staff will be trained and know how to detect and manage and prevent eye disease in children. And our longer term goal, again, is policy change at the level of the World Health Organization so that they include eye care for children across the whole African region. So this is an audacious goal, and I will put it to you that new interventions, if they are going to be taken to scale and to reach the populations that need it, policy is the way to go. And to get the evidence for policy, you need to do this kind of research. Thank you.
Thank you, Claire.